Despite mounting evidence linking obesity to cancer, weight management programs continue to emphasize diabetes, cardiovascular disease, and metabolic syndrome, while leaving cancer prevention largely out of the conversation. This critical omission represents a lost opportunity, both for saving lives and for enhancing the credibility and urgency of obesity interventions. As the scientific understanding of how excess body fat contributes to cancer deepens, the silence surrounding cancer risk in obesity care has become not only medically unjustified, but ethically troubling. Obesity is now recognized as a causal factor in at least 13 types of cancer, including some of the most common and deadly: breast, postmenopausal, colorectal, pancreatic, liver, endometrial, kidney, and esophageal cancers, among others. The mechanisms linking obesity to cancer are complex and multi-layered, ranging from chronic inflammation and hormonal imbalances to insulin resistance and immune dysfunction. These effects do not simply increase cancer risk, they also accelerate tumor progression and worsen survival outcomes. Yet, despite these well-documented connections, most weight loss programs, even those delivered by healthcare providers, fail to communicate cancer prevention as a core benefit of reducing body fat. Part of the problem lies in how obesity is traditionally framed in medicine. The dominant narrative positions obesity as a risk factor for metabolic dysfunction, focusing almost exclusively on type 2 diabetes, hypertension, and dyslipidemia. These are, of course, serious concerns, but they have overshadowed the oncologic implications of excess weight. As a result, patients pursuing weight loss are rarely educated about how managing their body fat can dramatically reduce their future cancer risk. This gap in awareness means that many individuals, especially those at high risk due to age, gender, or family history, miss a crucial motivator for sustained lifestyle change. Even major public health campaigns and national guidelines often fall short in this area. While some documents acknowledge the obesity-cancer link, the messaging remains muted, technical, or buried beneath broader goals. Cancer prevention is not foregrounded in the way it is with smoking cessation or HPV vaccination, despite the fact that obesity contributes to a growing share of preventable cancer deaths worldwide. This lack of visibility reinforces the false perception that cancer risk is out of our control, genetically predetermined, or unconnected to body composition. In clinical settings, the absence of cancer messaging in obesity treatment also affects how seriously weight is addressed. Providers may hesitate to bring up weight management for fear of offending patients, or they may discuss it only in relation to blood sugar or cholesterol levels. Yet the evidence suggests that even modest, sustained weight loss, especially before or during midlife, can significantly reduce cancer risk. For example, in postmenopausal women, losing just 5 to 10% of body weight has been associated with lower incidence of breast and endometrial cancers. Bariatric surgery, one of the most effective obesity treatments, has been shown to reduce long-term risk of obesity-related cancers by up to 33%. These findings are rarely emphasized in patient counseling. The failure to integrate cancer prevention into obesity care is not just a missed opportunity, it perpetuates inequity. Populations with the highest obesity burdens, including low-income and minority groups, also face disproportionately high rates of cancer mortality. These communities are less likely to have access to preventive care, less likely to receive timely diagnoses, and less likely to be counseled about modifiable cancer risks. Ignoring the cancer dimension of obesity means neglecting a key lever in closing health disparities and reducing preventable suffering. Moreover, by not linking obesity to cancer in public messaging, we weaken the motivational power of weight management programs. Many people fear cancer more than diabetes or heart disease. Highlighting this link could strengthen engagement, particularly among populations who might not otherwise respond to standard metabolic warnings. Patients deserve to know that managing their weight is not just about looking better or improving glucose numbers. It is about reducing the risk of one of the most feared diseases on the planet. To address this blind spot, a paradigm shift is needed. Cancer prevention must be made a central pillar of obesity treatment, from primary care and public campaigns to structured weight loss programs and bariatric surgery counseling. Healthcare providers should be trained to deliver clear, evidence-based messages about the obesity-cancer link, and patient education materials should be updated to reflect the full spectrum of benefits associated with weight loss. Research into obesity interventions should measure not only metabolic outcomes, but long-term cancer incidence. Prevention strategies must reflect the reality that cancer is not an isolated disease. It is deeply tied to the metabolic environment of the body. Until obesity is framed as a cancer risk factor with the same clarity and urgency as tobacco or radiation exposure, we will continue to fall short in prevention. The science is clear. What's missing is the will to connect the dots and to empower patients with the knowledge that reducing weight isn't just about managing chronic disease, but about fighting cancer before it ever starts.